Fiona Venner. I'm the Executive Board Member for Equality, Health and Wellbeing.
Good afternoon, everyone. Victoria Eaton, Director of Public Health at Leeds City Council.
Good afternoon, everybody. Adrian McCluskey, Councillor for Farnley and Wortley, and Support Executive to Councillor Venner.
Hi. Oh, sorry. Sorry for you, Shona. Hi, sorry, I think my mic's working now. I'm Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Active Lifestyles and Culture. Thank you.
Yes, Shona, please.
Sorry, everybody. I'm Shona McFarlane. I'm the Deputy Director for Adults and Health. Thank you.
Good afternoon, everybody. I'm Andrea North, General Manager at Leeds Community Healthcare, here for Sam Prince.
Good afternoon, all. I'm Nick Earle. I'm the Interim Director of Strategy, Planning and Programmes for the ICB in Leeds.
Good afternoon. I'm Caroline Barrier. I'm the Director for Adults and Health.
Good afternoon. I'm Jane Mashenko, Co-Chair of Health Watch Leeds.
Good afternoon. Councillor Conrad Hartbrook, Councillor for Rothwell.
Good afternoon. Councillor Lynn Buckley, representing our Woodley Ward.
Good afternoon. I'm Councillor Caroline Anderson. I represent Adlon Wharfdale Ward.
Good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor to this board.
Super, thank you everyone and welcome again. If you are watching online or watching later, you can find the papers we're going to be referring to online. If you just search Adults Health and Active Lifestyle Scrutiny Board Leeds, it will come up. And I'm going to pass over to Angela for the first few formal items. Thank you.
Thank you, Chair. Under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. And under item 4, please may I ask if board members have any declarations of interest? And I shall take silence as none. Thank you. And under item 5, we have received apologies from Councillor Kitcher. Thank you, Chair.
Super, thank you very much. Okay, we're going to move on to the minutes of previous meetings. So firstly, I'm going to do the meeting held on the 9th of July. I'm going to start with matters of accuracy. Are there any matters of accuracy that anyone wants to raise on those minutes? I'm not seeing anyone indicate. Angela, are there any matters arising that you want to raise?
There's none specific in terms of any information requested. It's just to note that there are issues that will actually come back to this board that's linked as part of the themed meeting around addressing health inequalities. So just to note that, Chair. Thank you.
Great, thank you very much. And then the second minutes we're signing off is for the call-in meeting, which Councillor Gibson kindly chaired in my absence. So again, ask the board for any matters of accuracy that they want to raise. You happy, Councillor Gibson? Yeah, great. Yep, I see agreement, so we'll take those as a matter of record. I think afterwards you'll need to sign those minutes, Councillor Gibson. Okay, so we're going to move on to the first substantive item, which is on page 25 of your pack. And firstly, Councillor Arif, do you want to make any opening remarks?
Yes, Chair, I do, if I may. So, first of all, I just want to say it's genuinely a pleasure to introduce the Home First programme report. Over the last 2 years, the Home First programme has been working across the health and care partnerships to improve the city's intermediate care services. The programme team last attended Scrutiny, if you recall, back in October 2023. Whilst the programme was in its early or infancy stages, they are here today to provide the board with an update on the progress made, work which is still ongoing, as well as the impact this vital work is having for people, staff and our system. The Home First programme provides a really positive example of partnership working on a key priority which is having a great impact on such a challenging issue. As the report highlights, the programme has improved people's outcomes, which translates into a significant financial impact. We have also seen a shift in the ways of working together between partners, and it has allowed us for us to better use collective resources. There is great progress to be celebrated and lessons to share, Chair. I'd like to extend my thanks to Megan Rowland. She's not here today, but I believe she will be watching, and all the staff members who have been involved in the programme so far and have been instrumental in its success. I will pass over to Nick and Caroline to take it from here. Thank you, Chair.
Thank you very much. We do have a presentation. I don't know if it's going to be coming up. There we go, thank you. We'll go to the next slide if that's okay. Lovely. If you don't mind, I'll just take 2 minutes just to rehearse again, just to recap on the reason why we decided that we should invest in working with our partners Newton to transform our intermediate care services. So this first is that our intermediate care services weren't really delivering successful and good outcomes for citizens. We were finding still that too many people were spending more time in hospital following admission and even at the point of having been ready for discharge, there were delays and we weren't able to get people out back home quickly enough. We were having to rely quite a bit on short-term bedded care, residential or nursing care, and we were commissioning that primarily from the independent sector at considerable cost, and also without the therapy input that people need from a short-term bed in order to then be able to go back home again. So people were deteriorating as a result of not having therapy wrapped around their short-term bedded placement. So, you know, many older people were being deconditioned in effect by default, ending up in a short-term bed because we couldn't get them home quickly enough. So really not the best outcomes for people, not the best outcomes for their families. Our staff also felt that, you know, they weren't delivering the best for people either. So a huge opportunity. We also recognised that there was a significant cost to people having to stay in a hospital bed longer than they needed to, and also going into a care home placement when they could have actually gone home instead. So from a financial perspective as well, there was an imperative to do something. And Newton worked with us across the system for about a 3-month period to do what they called a diagnostic of how our system was operating at the time. And what they found was that if we changed our processes, streamlined and simplified our processes and put the right services in the right places, then more than 400 people every year could be supported to recover at home following a stay in hospital. That people were spending twice as long as they needed to, even in some of our community recovery hubs, in our step-down beds that we already have in place. That they found also that we weren't doing enough around avoidable admissions, and that 1,700 more people could have been prevented from needing to go into hospital had we got to them at home early enough. And quite critically, 100 long-term residential placements could have been avoided each year through better usage of robust intermediate care services. So that's why we decided that we needed to do something quite transformational, bring in our whole system partners together. So that's NHS organisations, the council, and our third sector partners as well, because they're vital in helping, particularly around the avoidable admissions, but also getting people home. So where are we up to now then? So the impact that we're seeing, I'll just take you through some of the numbers and the narrative on this particular slide. I'll focus on one or two particularly, if that's okay. But what we've found already, and this is the performance data that we have got, we've got live data very comprehensive, very evidence-based analysis, which shows that we are already 157 more people are able to go home after a period of intermediate care instead of going into long-term care, bearing in mind that our target was 100. We've exceeded that quite considerably, more people going home, so we're over performing in that. Another one that is really particularly important and really significant for our whole sector is that there has been a 32% reduction in no reason to reside. So people who are in hospital who are no longer needing a hospital bed, a 2% reduction in their length of stay. And this is particularly people with complex needs, the people that we find most difficult to get out of hospital and get home again. Our target was 9%. So you can see the absolute impact that has been made and the financial implications of that you'll see in later slides are significant. The other data that I want to just point out is on the top right hand corner. It says minus 57 people fewer adults admitted to hospital each year when our target is 1,700. Now, that's because we take the snapshot of a particular month, and in this case it was August, and use that to explain the position for the whole year. But for the most recent data shows that 786 fewer adults have been admitted into hospital. So our prevention offer and our avoidable admission offer is actually having quite an impact. We're still short of the overall target. We recognise that, and we've got quite a lot of work ongoing to focus a little bit on enhanced care at home, supporting people to stay at home when they might. For example, if somebody falls, instead of immediate ambulance conveying people into hospital, we have a different approach to check that people can be supported if they're well enough to stay home. And also what we call virtual frailty, supporting people in their own home should they experience some sort of health episode. So quite a significant impact already, and we're only sort of 3/4 of the way through our first part of the Home First programme. On the bottom of the slide you'll see a little table, and that shows the 5 different programmes of work that have been underway over the last 18 months. And what it shows is that almost all of them are at that point where we've not just designed and piloted and tested the model of work, but it's sustaining and it's now handing over to operations as business as usual. The only area that we're still working on is around the transfers of care, and that's partly because of staffing implications and resources around getting that approach rolled out across the whole of the different wards within the hospital, in terms of having a multidisciplinary sort of presence on the wards, on the more complex patients' wards, to work with people and their families very, very early on, pretty much almost as soon as they're admitted, to start talking about and thinking about the plan for when they're going to be ready for discharge, bearing in mind we're talking about really quite complex needs. So that work is still well underway, and we're not quite ready to say it's there and it's business as usual, but you'll see that we're making really good progress in the other areas of work streams. I'm going to hand over now to Nick for the next couple of slides.
Thank you. So I will avoid talking through this slide in detail because it's in the pack as well, but what I wanted to do here was to show how that focus on improving people's experience and outcomes, and those achieving reductions in stays in hospital and getting more people home first, can also be translated into a financial equivalent value. So we use our resources to care for people in hospital. If they're not staying a day when they don't need to be there, we can redeploy those and use them elsewhere, and we can put an estimated value on that. So those numbers on the slide previously have a target associated with them, and when you convert that into a financial value, you can look at each area of the programme and say, well, actually, So if I take the third big column down on transfers of care, if our hospital no reason to reside length of stay has gone down by 32%, and we manage to maintain that for the whole year, that's equivalent to about £9 million worth of savings across the system. And different partners will see those savings appear in different ways. So in the case of the hospital, actually it frees up resource for them to use those staff elsewhere. For city council colleagues, it may be that actually we're avoiding people going to long-term care and therefore not spending that money there, and we can invest it elsewhere as needed. That's obviously of critical importance at the moment in the city, given the overall financial position we find ourselves in. The columns to the right-hand side, you'll note that there's a diagnostic target value. So that was what we estimated the opportunity was at the start of the programme. And there was also a stretch value, so how far we thought we might be able to go if all things went according to plan. And you'll note that the current programme performance on most cases is somewhere between that target value and quite often pushing close to that stretch value. So it's really going quite far as we think we can with that, and producing some real efficiency across the city. If we just turn to the next slide, you can consider that on an annualized basis. So the best way of describing this is to pick a month, let's say January, and say if the programme performed as it did in January, it would make an annual saving to the city, noting that point about where that saving lands will be in different places, of just under 15 million there for that particular month. And actually the next month and the next month and the next month you can see is slightly increasing. So we're improving that performance as we go, and we're getting very close to that high case value at the top. So the latest month that we've got on the slide for August, we're achieving nearly £25 million worth of efficiencies across the city in different sectors collectively. And so the task now moves from having achieved that for 1 month and estimating the impact across the year, trying to make sure that we can sustain that and embed it in our ways of working as a city. I'm going to hand back to Caroline for a case study and then we'll wrap up.
Apologies, sorry. This particular case study is taken from people who have experienced going through going into hospital, and then the planning in advance at the earliest opportunity of getting somebody back home again, because that was their desired intention. And I mean, you can see on the slide that, you know, we were getting responses back from a family member, a carer themselves, saying that they were really, so this is the daughter of the person who was in hospital, really keen to get you know, their parent home at the earliest opportunity, and not to delay and compound the person getting frailer, really using sort of the multidisciplinary approach that I mentioned, whereby we've got social workers, we've got therapists, we've got care coordinators, hospital discharge coordinators, all working together, people from different organisations coming together and functioning as a team on the wards to make decisions rather than making decisions in their respective disciplines. So doing it together and really sort of doing whatever possible to get people home wherever possible. I mean, this case study shows right at the end, you know, months later, in a chance encounter, the patient's daughter immediately went to the case manager and was really grateful for, and explained how what the impact was that her mum was able to go home after that stay in hospital, when it was looking likely that if it hadn't been a coordinated approach, she may have by default ended up in a care home placement. But we were also getting feedback from staff around what it feels for them, whether they feel that the outcomes for people are improved, and again, really getting a better sense of staff not feeling frustrated by processes that don't work, by delays that are built in because we've got so many layers that people have to go through. So this slide was just a little bit of feedback from the daughter of patient and also feedback from staff around their experiences. It's really important to note that we are continuing to gather that level of information because that's the sort of evidence we need to demonstrate the improvements and the impact of the improvements that we're making through this programme.
Thanks. And just to bring us to the last slide on sort of wrapping up and next steps. So the focus of the programme is now moving towards completing that rollout of that transfers of care model. We continue, so the slide we saw on the monthly figures, we continue to review those every single month. And part of that is about embedding this culture and way of working across the team of looking at where we're performing well or less well, making sure that we understand people's experience as they pass through care and working out where we need to act or do differently to keep within those target parameters that we set early on and, where possible, surpass them. Beyond that, there's going to be a bit of a move towards making sure that we've captured that learning and shared it across the city, so that this is obviously a big transformation program across multiple partners. There's a lot of learning within that can be shared elsewhere and used by other colleagues, and it's something we want to sort of celebrate and share and make sure people recognise and use. And then looking longer term towards the future, particularly quite apt given the report coming later on our ageing population, but we know that the over 80s in our population is going to grow, and we know that we need to continue to do more to support them well, and this is one aspect of that. We've been looking at what that trend will look like over the next 5 to 10 years and trying to plan using this service model approach for building and designing services that will support them in a better way. And allow us to cope with that continually expanding population. We call that the blueprint, and it's referenced at the end of the document, but that's very much about saying, okay, once we've embedded the changes, once we've communicated and changed our ways of working and our cultures, how do we make sure we protect that for the future and those people that don't need the services now but might do in 10 years' time, and make sure that we build that capability within the city. So I think that's it from us, and thank you.
Super, thank you very much. I'm going to open up to questions from members. So if you just indicate in the usual way, I'm going to start with Councillor Gibson.
Thank you, Chair, and thanks for this report. It's fantastic. It's a great initiative, and it's obviously bearing fruit already, as you've demonstrated through the statistics. Part of the report, you mentioned housing. Obviously, we're all aware of the social care crisis. It's been talked about for a long time, but there is actually a housing crisis in this country. It's unfortunately, it's not been talked about enough. I think we are starting now to hear more about it from our leaders, which is great. But you mention it in the report that there's no way of sort of sidestepping that issue. But you do talk about a sort of sticking plaster solution, which is houses where people can go in. I think that's what this is trying to say. That's interesting. I've not heard of that before. I think it's a good initiative in the interim whilst we sort the housing crisis out. But just wondered if you could explain a little bit more about that, please.
I can have a go. I have to be honest with you, I don't know the detail of what is being proposed, but just to echo your point, we've recognised that a lot of people are, for want of a better word, stuck because they need adaptations doing to their home. Their home isn't quite suitable for them to return following a fall or an injury. And there are also a lot of people who probably don't, are actually homeless, don't have a a fixed address and have been either sofa surfing, as the phrase might be, staying in different people's families' homes or friends' homes, or even sleeping rough because they don't have a home of their own. So there's nowhere for them to return in terms of returning home. So we're very mindful that we get our housing colleagues and work with our housing colleagues really early on when somebody is admitted into hospital and we know that either their home is not suitable for return or they have no fixed abode themselves. So to look to see what temporary solution could be put in place. We've been talking with our housing colleagues for a while around a whole various different cohorts of people who require suitable accommodation and move on short-term accommodation as well, which will allow them to stay for a short period of time whilst their property is work is done on their property, ramps fitted, grab rails fitted, more longer term work, or where they actually do require suitable level access accommodation. But that is working with our own housing stock, but also with the private market to identify whether we can utilise some of that housing stock. I'm not able to give you a little bit more detail on that specific project, but I can certainly find out and see where it's got to, if that's okay.
Yes, thanks for that. Just that's good, thank you. Okay, I'm going to bring in Councillor Ritchie.
Thank you, and yeah, I agree as well. It's a really positive report, and to get better outcomes and a financial saving is really the holy grail, isn't it, in many ways? So that's great to hear. Just a couple of things from me. I am intrigued on the sort of the staff survey, that although it's a majority, but 76% agreed the model benefited the patient. I'm intrigued in why the details on why the other 24%, if they were negative about it or if they thought it made no difference, but just digging into that. Sorry to, maybe analyse a slight negative, but I am interested because it seems from the report that can't imagine anyone not seeing the benefits. And then the second question around this increase in demand. There's obviously a number of factors. Councillor Gibson alluded to one of them. The main one being the population growth. But have you actually looked at kind of the risk factors that feed into that? So things like staffing, the adaptations process which you mentioned, extra intermediate care places, etc. And you'd mentioned the housing. So just on that, does that factor in our additional extra care capacity that's planned in as well? So that's it from me. Thank you.
I'll take the first one. Yeah. Okay. So in terms of staff survey responses, I'm sure you'll appreciate that there will always be some staff who are not very happy about changing the way that they're being asked to work. I can give an example because I think this was a big example, a real sort of sticking point to begin with, but it's very, very different now. So, for example, our hospital social workers were entirely hospital-based. So they would work with people who were in hospital. They wouldn't then follow those individuals out to see them going through intermediate care recovery hubs and then home, for example. We changed the way the hospital social work team works and operates so that they were sort of almost like case worker for an individual, then following that individual when they moved out of hospital into a recovery hub, intermediate care bed, until they got home and were settled, and then they'd do a review. And some of those hospital social work staff were saying, no, I don't work out in the community, I work in a hospital setting, and didn't like the changes that were being proposed, even though we were very clearly demonstrating that it was a more efficient way of working and better outcomes. People weren't being handed off from one worker to another team. They were followed all the way through. And only once we were working through that did staff begin to think, okay, you know, I need to adapt the way I'm working because I can see the wholesale benefit and, more importantly, the benefit for the individuals concerned. So not everybody has warmed to being told that they need to work in a different way. And that is, for us, quite a key point around how effective our communication is with our staff, so that they understand the reasons for the changes and see that that results in better outcomes for people and stops delays and the like. I'm not quite sure, and Shona might be able to come in, but I'm not sure when the next staff survey is going to be done, because we are doing them. We did them right at the beginning to measure people's views of how their the whole demand and flow in and out of hospital was operating. Then we ran a similar survey some months later, just to get a temperature check on whether we were getting the buy-in from our staff and they were understanding our rationale for some of the changes. And it may well be that another survey is due. Can I pass you on to Shona? She'll know better than me.
Thank you, Caroline. Yes, the latest staff survey is live at the moment with a hand-in date of the end of this week. So we'll be in the process of evaluating it from next week, and the results will be due out quite soon.
Yeah, thanks for that. I understand sort of resistance to changing the model, but the actual question that's presented here is staff agree the model benefited the patient. So you could still be hostile to changing your ways of working, but are you saying that perhaps influenced the result of the outcome? An analogy for me would be people don't like paying extra tax, but they will recognise perhaps that tax can deliver benefits for society wider. So that's all I was kind of focusing in on. For those, you know, if anyone had any specific reasons why they could say it hasn't benefited the patient.
I think part of the issue is that not all staff see the person all the way through their journey. So actually at the point when the person really benefits from the outcomes, they're at home, they're settled, they're enjoying their family around them, but the staff themselves are still in the hospital or have moved on to other cases and don't see that final step when the person has really benefited. And I think there's just a slight disconnect that by telling more of the patient stories like we've got in the pack, the case study, that actually the staff will start to see the whole process.
Thank you. That's an interesting, a really interesting line of questioning, Councillor Ritchie. I think it'd be good to get an update on the latest staff survey, and I think it'd be helpful to know that if it's not more positive, to share some of the comments, just so we can read through them. But I think that's it's a useful line of questioning. Okay, thank you very much.
Did you want us to answer the demographic question? So just keep it as short as I can, but essentially those forecasts are by age group. And if you, certainly from a health perspective, if you look at how many staff you need or how much resources you need or how much we spend per person against age, it looks a bit like a U. So start of life, birth, we use a lot of resource and staff, and end of life, a lot of resource and staff. So we've broken it out for those over 80s precisely so that we can look at those future staffing risks and needs. Because we know if we just did a forecast for the over 65s, for example, we'd probably underestimate a little bit about how much staff we'll need to support them adequately.
Thank you. Okay, I'll bring in Councillor Anderson next.
Thank you, Chair. I'm a big advocate of the Home First programme, and thank you very much for the comprehensive report. Can I just ask whether there's any work going to be done or has been done on readmission rates of people who maybe perhaps within a 2-month period, a 6-month period or a 12-month period, and the reasons, conditions and any links, what might be learned from any readmissions to hospital? Because it's like the other side of the balance sheet, isn't it? And you've got lots of savings mapped out there, but obviously readmissions would be costly and would, you know, take away from those savings. Thank you.
So that might be one, if it's okay for us to return to. So I know we tend to focus on readmissions within a shorter time frame than that. And actually that data for those longer terms would certainly be of interest in terms of actually how well are we supporting people over that longer time frame.
Thank you. Do you have the shorter time frames just to comment initially now?
Not to hand.
Okay.
Just pick those at random. I don't
Yeah.
know whether any work was done on readmissions at all. I assume there must be, because it would be an important factor in any hospital's discharge programme.
So we have counts and trackers within the system visibility dashboard we use on readmission, but they're not set in a specific time frame, or they're certainly not over that length of time frame. So that's the bit that I think we need to come back to and say actually over 1 month or over a stay in an intermediate care bed, we can say what proportion of people are readmitted and how that varies by age or by situation. But actually over saying, well, actually once they're home, what does that look like 6 months later is not something that we've got.
Thank you, that'd be really helpful. And I think it'd also give an indication whether the care package at home is appropriate or is working. Yeah, thank you for that. Yeah, thank you. Okay, so that's another piece of follow-up for you, I'm afraid, Nick. And we're going to bring in Councillor Wandry next, please.
Thank you, Chair. I think in some ways my mind was following the same track as Councillor Ritchie's, so I will try not to duplicate what he's asked, the questions that he asked. Except there's one thing I would like to duplicate is just to say congratulations on sort of devising and implementing this this excellent initiative, and I think, as he says, when you got together a improvement in the service that we're delivering and a financial saving, that's something that we really need to be celebrating. I was interested in the written report to the reference to the system-wide event in early October, a sort of appraisal, and I wonder if you could say a little bit about that. The reason I'm asking is I'm thinking of when, as a result of the work that's been done so far, we might be able to see actual reductions in spending that can be reported onto finance as opposed to projections, and might we get an impact on the in-year overspend in the current year's budget, as well as future projections. I'm mindful, and this is where I don't want to go over the same ground as my colleague here, that the sort of demographic pressures that militate against saying, well, we've done really well here, and that this is going to continue for years ahead. There's sort of a danger of the demographic changes eating up what we've done there. But I wonder if you could say a bit about that, please. Thank you.
Yeah, I'm happy to say a little bit, and I think Caroline might also want to add some bits and pieces. So I guess the first point to make on the demographic changes eating the savings, I think it's a case of making sure we're comparing where we would be if we didn't do this. So they may be eroded with demographic growth, but if we didn't do this, we'd be in a far worse position than this stands us into. And the second point, and I suspect this is where Caroline might want to come in, is around those savings are being realised in the system, but they're realised in different ways by different partners. So one of the things you might see in the hospital, for example, is although we might value a stay in a bed for 1 day at £300, say, actually the more people that you get home and the fewer people coming through to hospital, some of those savings then accrue as improvements in performance, or some of them you have to close a ward, and then you're like, okay, now I'm not employing the staff, or now I can redirect them. And each partner in this programme is working through and signing off those savings and then deciding where it is and how it is that they convert those. And I suspect Caroline might want to come in on the council's perspective for that.
Thank you. Yes, from the council's perspective, we were anticipating in-year savings this year, and then building in over a 3-year period a significant savings target in the region of about £6 million. So, and indeed we have seen more than we were expecting. We were thinking that the programme would take quite a long time to implement for us to then see the financial benefits, but indeed we've already seen them. So partly that has been because we've not had to place people in short-term beds, so we've ceased spot purchasing short-term beds at £1,000 a week, where we were using those beds previously. People were discharged to those beds on a temporary basis and sometimes staying there for quite a long time, 4 or 5 weeks before we could get them home. We're not paying that cost anymore, that charge to purchase independent sector care home beds on a spot purchase basis, and we're getting more people going through our own recovery hub beds, so we're utilising that better. And the biggest success has been in our active recovery service, which is our reablement service, which is delivered in partnership with LCH therapy staff. So our care workers in our skills reablement service working together with LCH therapists, getting people home. The number of people that are now being able to go home through that pathway has increased substantially. So whilst it's been at a cost for us to have, really geared up our active recovery service, it has been to the benefit of not having to buy services from the independent sector in the main. So we have seen that. The problem, of course, is I think you've alluded to, that we've had such significant financial pressures in year that what it has done is it's reduced those pressures rather than helped us to say, right, okay, we are under budget. It's sort of cushioned the blow that we already have around demand for people who are not going through the hospital system but who are at home, who are then needing care and support services. So yes, we can absolutely track and evidence the savings that have been made, but all they've done is reduced our overspend position, and we're anticipating that will be for the next couple of years too. We've got something in the region of a £3 million savings target in the next financial year for stopping people going into long-term residential nursing care and getting them home, and we think we will be on track to deliver that.
Thanks for that. That's very, very helpful. I'd just like to say, assuming this continues to develop as you'd expect, please do make sure that it's celebrated as widely as possible, and that we get the good news out there of a good example of large public sector organisations driving efficiency. Thank you.
If I could come in back on that, we are looking at opportunities whereby we've been invited to go and talk at many regional events or even at a national stage. Last year we were invited to go to the NHS providers event. I think that was in London. I attended that, and we explained how we're working across the system as a partnership, how we've got evidence-based we've got a dashboard which provides live data, and our decisions are made on the basis of that live data, and that was really celebrated. We've been invited again by the NHS providers event this year to go again to Liverpool to talk about our programme 1 year on and what we've achieved. We're also submitting nominations for awards around transformation, service transformation, partnership working, evidence-based practice. So we are absolutely doing our level best to celebrate our successes.
Councillor Av?
Yeah, just on the back of that, there is a celebration engagement event as well on the 4th of October, I believe. Hopefully I can ask, probably extend that invitation to Scrutiny if anybody's interested to come along, if that's okay.
That would be fantastic. We'd be delighted to do that. We'll do that, definitely.
Thank you. I'm going to bring in Jane next.
Okay, so I'm going to repeat some of the congratulations. Incredibly impressive impact, exceeding targets, fantastic, and outcomes as well as financial. And I had noted the connection to Victoria's report, and it's really good, and I'm not surprised, of course, Nick, that you are using that information to model what's the impact going forward of the demographic changes, because it's going to be hugely challenging, I think. I also expected that there would be national interest. It's kind of the right strategic direction. It's great to see the partnership working together like this effectively. So there's just a couple of little things really that I wanted to ask. One is, I'm sure this isn't reflective. So there's, in your case study, it was a chance encounter that got the positive feedback. I presume you are actively seeking feedback from people that go through the system so that it's not chance that you hear stories. And then the other thing was, on page 36, you recognise there's more to be done in terms of involving people, patients, in their discharge. And this was something that was particularly flagged up in the Health Watch report. So just if you could feed a little bit back about what's happening in terms of improving that, that would be great. Thank you.
I can certainly start, and then I'll ask Shona to come back in again as well, if that's okay, because it is her teams that are working, in the front face, as it were. Yes, we are looking to get people's experiences at the point at which they're starting their journey, and they're going through their experience of going into hospital, both people and their families, and then also checking back on them that have they felt that their views have been sought, they've been involved in the decision making. One of the things that we're trialling, one of the innovations that we're trialling around the discharge pathway is what we call a recovery plan. So every single person that is going into hospital who is going to then need some form of supported discharge has now got, it's an online, it's an app that our system has developed, which is a plan which will allow clinicians in the hospital, therapists, etc., to input information around the care and support the individual has had whilst in hospital, the treatment, the therapy they've had, to gauge families' views around what they want to happen for the individual themselves as well, if they are able to make informed decisions. And that recovery plan, the intention is for that recovery plan to then follow that individual out of hospital through intermediate care beds or through active recovery, so that all the way through, everybody that is supporting that individual to go back home again or to return to a care home placement, for example, has the full documentation around what has been delivered for an individual with their feedback in there as well, so that we're not operating in silos and people are not experiencing handoff over handoff over handoff, but there's a seamless transition through and everybody knows, the things that are important for that individual, the things that individual is saying they want for themselves or the family is saying. So that active recovery process wasn't at the start of the programme. It's only being tested and introduced now. So all the way through the programme, we're improving our communication and we're improving the feedback that we get from people as well. And your second point was around, what are we doing to ensure engagement at the earliest point with families, with individuals. I don't know, Shona, if you wanted to come in on that particular point in terms of your social work.
Thank you, Caroline. Really happy to do that. So the new Transfers of Care initiative that Caroline referenced earlier is a combination of clinician, discharge coordinator and social worker, in effect speaking to the person at the bedside. So at the point at which someone requires support to be discharged from hospital, there is a conversation that involves the person or the family. And that means that they are completely involved in the decision making about the discharge for that person from the beginning. So that's been a huge step forward, where previously decisions were made on the ward with somebody, but not with the team that was then supporting people to go out. So that's been a huge step forward. And if I can perhaps add an example of the feedback mechanism, Caroline, in the community care beds, we're using something called the patient reported outcomes measures, which is a horrible phrase. It translates into a really nice and easy to use survey that we've used with people in the beds that enables us to understand their appreciation of their journey and their feedback. And I've just seen one that's been done with family carers this last couple of weeks, presented really simply around what family carers think about the process. Were they involved? Did they have enough engagement? Were they satisfied with the quality of care? Even down to things like the cleanliness of the service that's being delivered. So we're able to pick up from people really quite early indications of where there is some dissatisfaction with the service as well as where they're happy. We did have some feedback from people who were physically sensory impaired. That came through on one of the surveys, and we were able to change the way in which the pack of information was given to people with sensory impairment, and we've now noted that the improvement from people who have sensory impairments has improved following those improvements. So I think what we're doing is utilising the methodology that Caroline outlined about do something, try something, measure, talk to people, feedback is actually working really well. Our frontline staff are enjoying having that immediate feedback to them. It helps them to feel more engaged with their role. Thank you.
I'd just like to say very thoroughly answered. Thank you.
Great, thank you very much. I can't see anyone else indicating at the moment, but I'll just ask something around the intermediate care. I guess one of the drivers for this programme is the no reason to reside people in hospital beds. I guess I'm very conscious about Councillor Gibson's point around whether there's enough housing stock for people to move to. I guess how do you, or are you looking at whether there ends up being this like no reason to reside in intermediate care, or what's your thoughts on that? Thank you.
Sorry, could you just repeat that last bit?
So if you're looking at, so the purpose of this is, one of the purposes is to reduce no reason to reside in hospital. I guess there's a risk, particularly given the housing crisis, you end up in a situation where you transfer no reason to reside in hospital to no reason to reside in intermediate care. So just wanted your comments on that and whether you're looking at that.
Yeah, I might pass to Caroline again shortly, but I guess the one of the things to note that this is doing is it is bringing partners together around those individuals as they go through that process. So when they move locations and where they go, we've got the whole team working out actually where are they going, what's going to happen, rather than passing individuals around the system without those conversations happening. It doesn't necessarily always solve those longer term structural problems around, you know, suitable accommodation, but it does mean that when we make those decisions, they're made in full awareness of that individual's needs, and that's certainly helping towards making sure we don't make or we reduce the number of poor decisions we make in that space.
And I'll add to that as well, in that our intermediate care beds, our recovery hubs, are only really available for people who have got rehab potential, not for people who just need accommodation, need a roof over their heads whilst their longer term accommodation gets settled. So they wouldn't be routed through to our intermediate care beds. The whole system, just as Nick says, recognises that if there's blockage in one part, then it's going to impact everywhere. So discharges from hospital and the drive to reduce length of stay in the hospital, pushing people by default into an intermediate care, will have a knock-on effect, because then those people will be stuck in our beds instead of being able to go home, and therefore fewer people will then be able to go and get the benefit of an intermediate care bed. So that's the whole point of this programme, is that it's so well connected that we're not looking at, well, what does this mean for me and my service? It's about what does this mean for the whole pathway, so that we don't create inadvertently pressure elsewhere and blockage elsewhere. So very, very clearly, somebody who has got rehab potential will go into an intermediate care bed wherever possible. If they don't have rehab potential, but they need somewhere to stay for a short period of time, that's where we've got to explore alternative accommodation options. So very clear pathways there.
Thank you very much. That's really clear. Thank you. Just one follow-up. Are you going to monitor no reason to reside in intermediate care?
We are doing already. We have got a target around no reason to reside in intermediate care as well. In our recovery hubs, we're not doing as well for those. The picture does, the position does change depending on the need of the individuals, and the more people that we take through our intermediate care beds and our recovery hubs, where they've got quite a high level of complexity, the longer they're going to need to stay. But once they're very clearly defined as, well, actually, you know, their therapy and rehab potential has been exhausted, is finished, you know, they now are ready to be discharged, then we've got to move them. The reason why we previously had quite a high no reason to reside position within our recovery hubs was because we didn't have social work staff readily available to go in a very timely way to do an assessment in planning that person's next place, i.e. their return home. Again, part of the active recovery work has entailed having an identified social worker working with each of our intermediate care units, so that they know the individual from the moment that they've been admitted to that recovery hub bed, that intermediate care placement, all the way through. So they're tracking when a person is likely to be at that point where they're ready to go home. So they'll already be there. They won't come in once they've been signalled as ready to go home and starting the whole process of assessment then. So the whole model now is built around following that individual all the way through their time at an intermediate care facility.
Super, thank you very much. That is helpful. Okay, so I can't see anyone else indicating, so I'd just like to say again, thank you very much for this piece of work. It is really positive. I think clearly people prefer to be at home or somewhere other than a hospital unless they absolutely need to be, so having pathways is really positive. So thank you for that work, and thank you for the progress with that. So with that, I'll close the item and move on to item 8 next, which I'm quite looking forward to, is the Public Annual Health Report from Victor Eaton. We actually have a film to watch as well, but what I'm going to do is I'm going to ask Councillor Venner to make some opening remarks, then we're going to watch a film, and then I'll bring in Victoria, if that's okay. Thank you.
Thank you, Chair. So this is the annual report of the Director of Public Health. It's a mandatory requirement that the Director of Public Health produces an annual report, and this year's focuses on ageing well. It's got quite a delightful symmetry with last year's report, where we focused on little people. So last year's report was about children, and particularly children's, the impact of children on the pandemic and what life was like for them. And this report focuses on the other end of the age spectrum. As the Chair said, it has an accompanying film, as the last annual report did as well. And the report very much focuses on health inequalities, and it's already been to the Health and Wellbeing Board, where we had a discussion on it there. Just to pull out a couple of issues, one of the points that I made to Victoria and her team, and also at the Health and Wellbeing Board, was that I was really surprised that housing didn't come out as a more pressing issue, because for all of us councillors, particularly those of us within a city wards, it's 50 to 75% of our casework. But actually, I think if we were producing this report in 10 or 20 years, it would be a much more significant issue and potentially reflects the fact that currently a lot of older people are securely housed, but that won't be the case in years to come because there are so many people currently renting at middle age. So I think that's an issue that we will be facing in decades ahead. I think also, actually, to add as a caveat to what I've just said, I think we also do need to recognise that there are older people in our city who are kind of asset rich but cash poor, so older people who are living in homes they've lived in a long time, but maybe struggling financially. I think a really key point to pull out is that this report focuses on ageing well. It's not just a report on ageing, it's about ageing well. And I think a point Victoria was really keen to emphasise is that you don't have to age in ill health. It's not inevitable that older people have health problems. And that means that prevention is really important, and prevention from birth, because actually you're more likely to have health conditions in older age if you've had them at a younger age, if you've grown up in poverty, etc. The recommendations are summarised in the cover report. I think one of the ones that jumped out for me was about the importance of addressing isolation and the importance of social connectedness. And in the work that was done with older people themselves and with people who support older people, that came out in the top 3 issues for both groups, so both older people themselves and people who work with them. So I think the work we do through the third sector, through our neighbourhood networks, we've got the International Day of Older People coming up on Headingley Stadium, which will bring a lot of older people together. I think all that work's really important in terms of the effects on health and on ageing in a happy, healthy way of being isolated. I'll pause there, Chair, and we can watch the delightful film, and then we can hear comments from Victoria and her tea.
feel positive about my life. I'm not afraid to try new things and do things I enjoy because I don't really worry about what other people think. Getting older can be quite liberating in that way, actually.
I drive everywhere these days. It's not easy driving in Leeds. If you take a wrong turn, you can quickly get lost. I don't feel safe getting the buses anymore. Plus, you can wait for one for an hour, and I can't stand that long. In fact, I don't go downtown very much anymore. The gardens, parks and green spaces in Leeds are what I love the most. I think they do such a good job of fitting in little green spaces. It's such a wonderful city for that. I'm medically a lot older than I actually am. I've got diabetes, I can't walk very far, and I'm frail. I'm hard of hearing too. It's just very difficult. My autism was diagnosed just before COVID as well. Having a diagnosis for things is important. You understand yourself and your body more, and you can look after yourself better.
I like not feeling peer pressure now I'm a bit older. I get to do what I want. I enjoy working. I work full-time and I can choose to do what I want with the rest of my time. I like going to the pub and seeing friends and playing board games. Socialising helps me stay mentally and physically happy and healthy. Seeing people is important, in the pub, going for meals, playing badminton or going for walks. There are things I'd like to change to help me age better, like getting a bit more active, stopping smoking and drinking less. I do a bit at the moment, but I think I'd like to be a bit more physically active.
At the end of the day, ageing well is all about feeling healthy, happy.
I'm part of the community.
With the right people
Places and support in our lives.
We can all age well.
and enjoy life.
Thank you, Chair. I hope everyone could hear that well. It was a little bit quiet, wasn't it? So we'll make sure we send it out. I mean, if you search it up, it'll come anyway, but we'll get that sent out so people can always have a look at that again if you'd like to. So thank you very much for the opportunity to be here. Before we start, Chair, I just wondered if I could ask my two colleagues to introduce themselves because they're heavily involved in the work.
Hi there, I'm Helen Laird. I'm the Head of Public Health for Ageing Well, Leeds City Council.
Hi, Tim Fielding, Deputy Director of Public Health.
Brilliant. So we have some slides and I plan to go through them really quickly, partly to get to the questions and the discussion. Also, I'm really mindful that, as Councillor Venner said, we've taken this to the Health and Wellbeing Board and lots of other boards as well, and it's doing the rounds at the moment. So apologies for those of you who are on those boards, you've heard some of this before. It is a very broad report. The presentation is very high level, but obviously we've got the opportunity for a full discussion, which could take us anywhere into this agenda. So that's the plan. I've got just over half a dozen slides to go through very, very quickly before we get onto the discussion. Next slide, please, Angela. So just to follow on from Councillor Venner's introduction, just a few key points around setting the scene for the report. The report sets out where we are as a city and what further action is needed around ageing well. Lots of you will know that we're building on incredibly strong foundations of healthy ageing work in the city. Lots of people in this room are directly involved. Certainly Helen's world kind of revolves around this work. We are an age-friendly city. We have an age-friendly board chaired by Councillor Jenkins, and there's a huge amount of very positive work already going on. We've also collaborated nationally with the Centre for Ageing Better, and part of the reason for doing this report was to really support us to make decisions about where next with this really important agenda in the context of the pressures that we find ourselves in at the moment. So it's very much acknowledging the work that's already happening, and the fact that we have lots of colleagues who are already taking this work forward and have absolutely contributed to the report itself. The other thing to say, just by means of introduction, is the breadth of the report covers all of ageing well across the whole of the city, across all partners and sectors. So it is a very broad report, and the recommendations do reflect this. I'll go on to talk about that a little bit more. Thanks, Angela, for the next slide. So very briefly, one of the things we did last year when we were looking at children and young people, and this year around healthy ageing, is we wanted to make sure that we had people's stories at the centre of what we did. So the 5 people you saw on the film there were 5 people from many people we heard from as part of this work, and it's a really important principle in informing our findings and recommendations that we completely balance what we're hearing from people's lived experience of ageing in Leeds with the latest evidence and research and data for what and what that's telling us. So that's a basic principle of what we did, and you can see some of the figures here about the numbers of people we spoke to, as well as the number of reports that the team analysed. So it's a very comprehensive piece of work. The report does form part of our joint strategic assessment for the city around ageing well. So it doesn't kind of stand aside from the central processes of how we need to plan and deliver our shared priorities for the city. So it's absolutely embedded into our central strategy as a city. Next slide, please, Angela. One of the things that feeds into the conversation and links to the previous item is we wanted to be really clear around understanding the position for our population around ageing. One of the things that prompted us to do the report was this knowledge that Leeds is a very fast-growing city, and it has a younger demographic than other places. So we know we have generally a younger demographic, and that's pretty well known and talked about. What was less clear is a very thorough understanding of our demographic and projected populations around ageing. In the National Chief Medical Officer report last year, there was a strong narrative around cities need to focus on their younger demographic, and actually where more older people live in our rural and coastal communities, these are the areas that really need to understand and respond to the challenges of ageing and healthy ageing. And that didn't sit right with us, so we really wanted to understand what was the position for Leeds. So this slide, there's a fuller section on this in the report. This slide just gives some headlines for being really clear about understanding the population and the growth of the population. So that 1 in 3, we know that 1 in 3 of our citizens of the city are 50 plus. We know that over the next 10 years, the numbers of people who are 50 plus are projected to increase, which is the nearly 20,000 figure, the 19,300 there. We do have outward migration of people as they age to more rural communities, but we still have a net increase of people in the city. So this felt really important before we look at what we do. We needed to understand what population we're talking about. And the other important headline, I guess, to flag today is that we know, as well as the sheer numbers of people over 50, the characteristics of that population are also changing. So there are more people over 50 who are living in our more deprived communities. And there are and will be more people over 50 who are diverse in all of its forms. So it's not a static older population. It is a changing population, and therefore we need to change how we work with these communities at the same time. So there's much more in there in the report, and happy to take any questions on that. But they were the things I wanted to flag in the presentation. Next slide, please, Angela. So this is a slide which potentially is the most important slide in the presentation, and it's actually not mine. It's Chris Whitty's slide from the national report last year, but it's incredibly relevant nationally, but it's incredibly relevant locally. And basically what this shows, and it's in the full report, so hopefully you had a chance to look at it, is that we know that we've got around a 12-year gap in the city in overall life expectancy, generally from our poorest to richest communities. So that's quite well kind of discussed and well understood, and there's lots of work around trying to reduce that. What this slide shows is we have an even bigger gap around the years that people spend in healthy life, and then which is the bit in blue, and the proportion of people's lives that is spent in poor health, which starts and then continues till the end of their life. And the top block is the average expectation of healthy life expectancy for people in our 10% nationally in the 10% poorest communities, and the bottom slide is for people in the 10% most affluent communities. So as well as having a life expectancy gap, we've got an even bigger healthy life expectancy gap. So if you live in, as 1 in 4 of our population do in the city, if you live in one of those 10% nationally most deprived communities, on average, you're likely to hit the period of ill health for the rest of your life at 52. And if you're more affluent, that's so much later in life, as you'll see from the bottom chart. So on average, that's 52. And the really important message, Councillor Venn has alluded to it, is that a huge amount of that is preventable poor health. You know, all of the things that we know make the most difference to people staying healthy for longer apply to being able to shift that top period of poor health for those 1 in 4 people of our citizens in the poorest communities, and really compress that period of poor health later in life. So the central challenge of a lot of what this report brings out is how we do that. This is a national conversation as well as a local one, but absolutely it is the case for Leeds. And just to end this, this is not only a good thing to do for people and their families and themselves and the communities, but in terms of the sustainability of our public services, including our NHS services, and again referring to the last item around keeping up with demand for care. This agenda is now being seen as absolutely central to having a sustainable NHS and public sector. So there's a huge call to action around all the things that we know that make a difference in prevention and early intervention to support people to stay healthier for longer. And the final kind of strapline on this is that it's really clear we cannot treat our way out of this situation. It has to be done with prevention and early intervention in order to be sustainable. Next slide, please, Angela. So really quickly, just to run through the last few slides. Councillor Venn has already partly referred to this. when we really listened to people, we listened to what local people, 50 plus, told us about what's important to them to be healthy. We listened to professionals who work with people over 50, and the list of what came up as the most critical things to support people to be healthy were almost identical. And as Councillor Venner said, being socially connected was so important to people. So there's just something really practical there about when we are designing services and programmes, particularly in this digital age, how do we ensure that doesn't reduce social connection in the way people live their lives? But you can see the list there and how similar they are. Next slide, please, Angela. This is really important. I'll cover it very briefly, but it's really to acknowledge the breadth of work that's already happening in the city. You know, Helen could talk all afternoon around the range of services and programmes and interventions around supporting people to keep well for longer. We have an incredible thriving third sector around healthy ageing and older people, in Leeds Older People's Forum. We've got so many assets. So the report is all around building on what we're already doing well. The challenge, as ever, is around, are these things kind of happening at scale, and are they joined up enough, and do people know about them? So there's something there just about how we build on our strengths. Next slide, Angela. I won't dwell on this because of time, but you'll see these are the key findings of the report. They all feed into the recommendations. So if we can just go ahead to the recommendation. So, sorry, the slide, the text is quite small, but they're all in the report. So again, not to go through in any detail, but you'll see that the recommendations are specific to different partners in the city, and sometimes to our partnerships that come together around healthy ageing. There are specific recommendations around prevention. The council and third sector partners have a key role in primary prevention to keep people well in the first place. Our NHS partners, which is recommendation 4, have a key role in what we call secondary prevention, that is working with people who already have risk factors or show signs of early disease or already have long-term conditions, to really work with our NHS partners to really scale up the targeted work we're doing around secondary prevention to keep people well for longer. There's specific recommendations in there about transport with our West Yorkshire Combined Authority colleagues, anchor organisations as employers, etc., and academic partners around further research. So I've whizzed through that, but I hope that's been helpful. I'll leave it there, Chair, and happy to take any comments or questions.
Councillor Venner.
Yeah, I just wanted to add something about prevention. That slide that Victoria described as the most important slide, personally I find really shocking because I am 52. So the thought that that's the average point at which people living in deprivation would start to live their life in an unhealthy way is horrifying, because I still feel like I'm young, even though obviously in numbers I'm not. But in terms of prevention, I think this illustrates why public health is important as a function, and why things like smoking cessation programmes, work around exercise, work around obesity and healthy weight. The reason they're important is because those are the kind of things that impact on people as they get older, with things like COPD and diabetes limiting the positive quality of life that people have. We also talked at the Health and Wellbeing Board about cancer screening, and the fact that in deprived communities, in terms of data, you have a lower rate of prevalence of cancer but a higher mortality rate. So obviously the lower prevalence isn't really lower prevalence, it's people not getting diagnosed. So we talked about the importance of cancer screening in communities, and using like the really fantastic work Councillor Arif led on with Victoria during the pandemic with Sam Prince as well, where we did outreach to make sure people were vaccinated in their communities, and we reached into communities that
would struggle to come forward and access mainstream vaccination services. And we need the same approach really with cancer screening and making sure we get into communities, both geographical communities, communities around deprivation, communities in terms of diversity, because we know we've got higher rates of death from certain cancers in diverse communities. So yeah, I just wanted to stress really that I think this report really highlights the importance of public health as a function and why preventative work is important from a young age. Thank you.
Thank you, Councillor Renner. I agree with you. Preventative is really important. It's something we have certainly talked about before in this scrutiny board, as you know. I also thought that chart, that graph, the healthy life expectancy verse is quite shocking. So I'm glad to see that this has been brought this year, so more work can be done on it and the focus can be brought. But I just also think there's some real positivity in there. So on page 62 of the pack, no, 78 of the pack and 62 of this specific report, overall, how happy do you feel in general? I think that paints a much more positive picture. And I think it's one of those things where I think we do need to recognise there's definitely more work to be done, but we shouldn't either be too negative about what it's like in the city. But I totally think we do need to do more stuff. So I'm going to open it up to questions if anyone wants to ask some questions. I'm going to start with Councillor Vontree.
Thank you, Chair. Really interesting report, and thanks for everyone who's put time into it. Clearly, there's a lot of in-depth research and some very detailed and thorough listening to people as well, and that certainly comes out of the comes out in the course of the report, and some excellent recommendations. Just picking up one thing that struck me that I wasn't really expecting to see was the emphasis on use of alcohol and the problems that and difficulties that arise from that. It's not the older age group isn't necessarily the people you immediately think of in terms of alcohol use and health-related problems and alcohol abuse. I'd like to raise a couple of editorial things about the report, actually, because I did notice that the executive summary section seemed to be duplicated. It appeared at the beginning and the end in exactly the same form. And there were also a couple of pages that seemed to me to be talking about children's issues, and I'm not sure if they were meant to be there. I just couldn't understand how they fitted into the whole. I think they were numbers. I've got a note here. Pages 122 to 125, using the numbering scheme on the report within the report, if you get the meaning there. And just one question I would like to ask is, who do you envisage being the recipient, the audience of the report? I'm just wondering who it was aimed at, because it's a very long document, and it seems to be aimed at a general readership. And for the all the hard work that's gone into it, I'm just wondering how many people do you think will read it end to end and thoroughly, or parts of it in detail, that kind of thing. Thank you.
Thank you, Councillor Vontree. Just I'll let Victoria come in a moment. Just in terms of the children's element, this is an annual report, and each year Victoria, statutory required, and each year she'll pick a subject. So last year she brought a report on child-friendly Leeds, effectively young people and the impact of COVID on young people. And so the 122 in the report is following up from the recommendations from last year, which was obviously a completely different topic, which is why it seems like it's a different topic. Hopefully that makes some sense, but I'll let Victoria come in.
Okay, thank you. That makes sense to me now. Yeah, thanks.
No, thank you, Chair. That's absolutely right. One of the things we do is make sure we've got a loop mechanism. So we make recommendations each year, and then they don't just disappear into the ether, but we kind of use the next year's report to update on progress on the last year's report's recommendations. So we certainly plan to do the same next year on this year's report. But Helen can certainly say more about how we're going to keep track of the action plan and the progress against recommendations, if that's helpful to come in on. And thank you. We'll have a look at if there's any other of those editorial issues in the report. Thanks for raising that. In terms of who it's aimed at, it's always a good question, and we always we're really clear we had to have that as an endpoint before we wrote it. I mean, because the nature of the agenda is so broad, the target audience was equally broad. So in a sense, the recommendations give a flavour of the target audience, because it's really aimed at all partners who have a stake in making a difference to this part of the population, which is pretty much everybody, really. So I'd say that I'd say it's aimed primarily at the sort of breadth of our kind of colleagues and professional partners. But I'd also say that it does have what we've found and what we've heard is it also has value for the general public. What we did last year with the children's one is we did a child-friendly summary of the report, so that children and young people could also read it, because they were part of the target audience. We didn't feel it was appropriate to do that for 50 plus this year, but we wanted to make the executive summary very user-friendly, use lots of graphics, not make it, take out jargon. So we've, the public are included in that target audience, and we've had some feedback from them that they found it quite more positive reading than they thought they might do, which reflects your comments, Councillor Scopes, because I think that there is this sense of kind of inevitable poor health that people feel is a result of ageing, and just that challenge to the fact that actually there's lots of things you can do to support that living well for longer and healthy for longer. I've had some really positive feedback from older members of the community to say it's really good to hear that, actually, and there's lots that we can do. But I don't know if colleagues want to add to any of that.
If I could just come into that, Chair, as well. I suppose just to add, and particularly on that point about ensuring, I suppose, that it gets used and that there's a value in the sheer quantity. I suppose a couple of points. Very much obviously accessible to the public and older people, but also very much aimed at partners. And I think the response from partners so far in it going around has been really positive, and it does feel like people have really taken it on board, really read the detail, and really taken it in the spirit it was done, and found that useful. Also, really just wanted to reiterate the point that Victoria made before, that you'll hopefully have seen, and the launch of the refreshed joint strategic assessment that we have, which is it's overseen by the Health and Wellbeing Board, jointly between partners locally. And as Victoria said, this does form the Ageing Well chapter of that. So the depth of analysis and the depth of detail in here is really key to actually giving that really rounded, in-depth picture of the circumstances and the needs, and looking forward for colleagues and partners that are using that joint strategic assessment to get that picture of older people going forward. And Helen may want to say more about it. Is very, very much leading the work, as well as having led the work in producing this, but also it's very much going to be feeding into the refresh of the age-friendly strategy and action plan that we've got, which is a whole partnership structure and one of the mechanisms by which we undertake a lot of the work that happens locally around older people, and covering a lot of the areas covered in this. And this will very, very much be the sort of foundation that goes in, and the sort of evidence base, if you like, that shapes that.
So yeah, as Tim suggested, the kind of longer report is going to be extremely useful to our review of the age-friendly Leeds strategy and action plan, which cuts across all the different categories and chapters within the report. I'm due to commence meetings with officers over the next few weeks and over the next months around kind of the actions that we've had in place in the action plan over the past few years, and then what is the director's report actually saying that we should be doing going forwards? What should we be doing differently? And what could we be doing more of? So that will be incredibly useful. And as kind of Tim and Victoria alluded, the shorter report is really extremely useful for our work with like some of the Leeds Older People's Forum partners, the Age Friendly Steering Group, so in a range of different ways. So yeah, as Victoria and Tim said, we've had some really good feedback.
Great. Okay, thank you very much for that. I'm going to bring in Councillor Hartbrook next, please.
Oh, I thought there was a queue ahead of me. Thank you, Chair. I think this report, I always look forward to seeing these reports each year because they are very thorough, they're very data heavy, but also very accessible and easy to read. And I think the video itself made Leeds look beautiful. I mean, it is beautiful, but it was very well put together. I'm particularly happy to see, unlike as well as what Councillor Venner said, that I'm rapidly hitting 52. So it does kind of make you think, oh, I'm in the cohort now. Leeds does a lot of very good work that doesn't actually have to cost an awful lot of money. Things like the lunch clubs, my own brother goes to one, and the community groups and things deliver an awful lot of value and actually drive an awful lot of good outcomes for people, often for peanuts. And I think one thing we could consider doing as a city is leveraging more stuff into those. I mean, I'll give you an example. It's not a lunch club, but we run in Rothwell a community kind of cafe once a month, and we're trying to get more outreach into there. So, I did one this last Saturday around kind of making sure that people were claiming pension credit where they could. And it's that kind of actually, while you've got bums on seats coming together for a community thing, talk to people about health, talk to people about other facilities, and it costs very little, often other than just a bit of somebody's time. And it doesn't even necessarily need to be a councillor or a council official if it's somebody who knows their onions. And a lot of people, especially in this cohort where you've got elderly people, they've been around the houses, they know the information, they may have done it for themselves. But actually, there's a lot of people, I think you touched on it, with either whether digitally excluded or just less aware, need that helping hand from somebody. But I think peer-to-peer working can really kind of pay dividends. There's a couple of bits in the report that I'd like to bring out, and I don't want to delve too much into it because otherwise it would veer into sort of some of the political stuff. I know this isn't what this group's for, but a couple of things that stood out to me. Page 82 of the report said that nearly 2 out of 3 people in Leeds aged 65 plus want to continue to live in their current home with support when needed. That means there's over a third who don't. And I think in the context of Leeds City Council sort of pulling out a provision on care homes, it's something to reflect on. I'd be curious as to what that sort of feeds into in terms of provision and choice later on. It was interesting to see. I think got a few smiles at this end. The driver in the video saying that driving around Leeds isn't particularly easy, but I think on page 90 of the report, there's a lot of really good stuff around people value access to local spaces and green spaces and parks. And there's also somewhere in the report that says actually most people, particularly in the 50 plus age group, access those facilities by driving. And obviously, with financial pressures that the council's faced, choices being made around cost of those. And I would be interested to get feedback as to whether that affects people's use of those facilities, because if people feel as though they could no longer afford to use them, usage may drop. But I think overall it's a very good report, and I think some of the information in here does feed into some of the choices we make wider as a city. So I would be interested to know, probably through this, whether some of the choices happen over here, and here start to affect adversely or favourably some of the wider kind of health issues in terms of access, etc. Thank you. Thanks, Chair.
Thank you, Councillor. I'll bring in Councillor Venner. Do you want to just turn your mic off, Conrad? Thank you.
Thank you. I wanted to respond to one point you made, and again, I'll try, Chair, to do this in a way that's appropriate for a non-political environment. It was the comment that you made about the council pulling out of care homes, and
I appreciate that we are closing 2 care homes, one of which is in your ward, though it is going to be repurposed. But the council isn't pulling out of delivering care. We've commissioned a series of extra care housing schemes which reflect how people want to live now. There is less demand for more traditional care homes and much more demand for provision like extra care housing, where you can live in your own flat but with access to communal facilities and other people, and you can have a full care package and live independently in your own flat within those provisions, one of which is going to be in your ward, I think, Sycamores. We've got Gascoigne House that we've just opened in Middleton. They're really high quality provision that enable people to take pets. They enable couples to stay together. So I just wanted to challenge that statement that we're pulling out of care, because we're not providing care in the way we have previously, but we are actually providing a range of really high quality care in the form of the extra care housing. Thank you.
Yeah, thanks for that, Councillor Leonard. I think it'd be helpful if we got some more details behind that number on page 82, because I think that's the question you're asking, is what does the other third want, which I think is a totally interesting question. Yes.
Yeah, Councillor, I did think very hard about that, because I think that the facility that's built in Rothwell is very good for a certain cohort of people. I think I would class that as living in their own home. So it's a question, because it is their new home. It's sheltered accommodation, but it's different. So I think the point is kind of understanding that demographic in probably more granular detail of what people want, because I think that purple box does sort of point you down one particular avenue. So get into more detail around actually what are the kind of the feedback of the types of homes and the types of living places that people want would be useful to publish.
Yeah, thank you. So I think asking about what the other third is, and I think I'm going to guess that you don't have that data to hand, Victoria or Tim, but I think that'd be very interesting. And I think the other point about green spaces, again, I think that is something I don't think they'll have to hand. But in terms of usage, say this year compared to last year, again, I think that'd be relevant data for us to request. Victoria, I see you indicate, so I'll let you come in now.
Yeah, no, thank you, Councillor, and certainly the whole themes around transport and access to green space were something that I welcome your comments. We'll take those back to the group, and I guess there is something around how we kind of look at that in the round in a different way. Given where we are, so I think there's something about transport more broadly. Just on the housing issue, I think to support what's already been said, one of the people's perceptions around older people and where they live is the overall the really small percentage that live in a nursing or care home. So it's in the kind of headline kind of stats at the front end in the exec summary, but from the 65 plus age group, 3% of people, 3% of that 65% age group do live in a nursing or care home, and often a lot of the conversations we have around housing needs and care needs of that older age group make an assumption of the proportion being higher than that. So I think that that again is a good news story, that most people, and even when you look at the population of 90 plus, people who are 90 plus, there's still a smaller population that people would expect that live in a nursing or a care home. So there is something around that third of people who don't want to live in their current home, might want to live in a different home independently, not necessarily in a care or nursing home setting. So I just think, we just need to not make an assumption that that's the other option of moving from current home to care or nursing setting. But again, thanks for the comments. We can take those back.
Super, thank you very much. Okay, I'm going to bring in Jane next. Thank you.
Thank you. great report, as ever. Very, very broad, but also detailed, and particularly value the fact that it's centred around lived experience and stories, as well as data. Brings it to life, and it shows what matters to the people of Leeds. People are sharing their emotional response to it. So I'll share mine. So very positive, all of the work, absolutely, that is underway in Leeds. But also a bit of, oh, crikey, look at the projected increase in the 70-plus age group in the deprived areas as well, which is where there's a significant challenge in terms of quality of life expectancy. So that's kind of my response, that kind of recognition of that challenge given our current context that we're living in, and kind of trying to anticipate how that will project going forward. I've got a specific question, and that is, do we know, trending over time, what the inequality gap in terms of that healthy life expectancy, has that been widening or narrowing? And I know that what we're wanting to do is to narrow it further going forward, but that's going to be significantly challenging, isn't it? So that's one question, the trends in relation to that. Another comment is just to say it's great to see the recognition of the risk of digital exclusion and barriers to both social connection and services. And that's something we certainly hear at Healthwatch. And the recognition of the importance of green spaces, which again is something that really comes across. And my last thing is probably an impossible question, so I recognise that. And that is, given the focus last year was on young people, and we know again that a highest number of young people live in deprived areas, and that's growing. We know that data's not looking great in terms of kind of obesity, and given these factors, if we tried, and I know there are so many unknowns, but if we tried to model those risk factors going forward, that's significant risk, isn't it, to the population health? And so we have to kind of really focus on prevention kind of before you get to 50, really, is what I'm saying.
Thank you, Jane. They were very useful comments as ever. Thank you. I'll start on a couple of those, and then I'll, if Tim wants to comment on the healthy life expectancy. I think that question about the projected, what we think might be coming in future generations is really important, and it sort of echoes what Councillor Venner before was saying around the kind of, we know that housing is likely to be an issue in the future, even though it's maybe not now. I think there are a few things that we know. This generation that is now 50 plus, we're seeing a generation behind that in many measures has poorer health indicators than this one, and therefore unless there is significant change in those health indicators, we're likely to see a 50 plus population with poorer health in the future than we have now if we don't do anything about that. And some of the big examples that came from the report include the one you raised about healthy weight and levels of overweight and obesity, and we know that the consequences of that not changing will play out in that 2 or more long-term conditions being, more widespread, and there'll just be more multiple morbidity that plays out in the population in the future unless that changes. The other big one is around mental health. So Councillor Scopes pointed out before that if you look at the self-reported mental health of the over 50 group, it's very encouraging reading, because most people say they're happy most of the time. If you look at that for younger generations, that isn't the case. And so as that younger generation ages, again, unless that situation improves, we will have poorer mental health for our older population in the future. So we can see where we are now, and we can see some of the stuff that's definitely coming down the tracks. So as well as needing to do the prevention work now to support people who are already over 50, it absolutely, this is a ticking time bomb of worsening measures for the future. So thank you, that's really important. In relation to that question about the healthy life expectancy, one of the things that we're really pleased to see is that there is more of a focus nationally on healthy life expectancy rather than just life expectancy. Where we are at the moment is that data is relatively recent, because it's been a recent change of emphasis, and we've tried really hard. The reason why I had to use a national slide there, and it can be completely applied to the Leeds population, is that we still don't have healthy life expectancy data at a local level for the Leeds population. So we can't do the same map for healthy life expectancy yet than we can for general life expectancy, but it should be coming soon. So what we have is relatively new data there to show the difference. Now, Tim may say something, because he's been closer to this, that adds to what I'm saying, but it's really early days yet. I mean, so we don't have, in my knowledge, evidence of that long-term trend, because it's not been long in capturing that data, but we should have going forward, because now we're starting to do that more, and it should get better in the future. My sense is, because we've seen this stalling over the last 10 years, which is now 12 or 13 years, since 2010 we've seen general stalling of the gap in overall life expectancy. So there's nothing to suggest that we haven't had that same, at least stalling with a slight worsening for the healthy life expectancy. But I don't have the data in front of me to evidence that, but we should do going forward. Tim, I don't know if there's anything you want to add to that.
Yeah, just very briefly. Thanks, Victoria. Just a little nod. I was just looking at the data pack for our Marmot City work as well, which has now gone live and is on the IHE site as of yesterday. So we're including some data packs that include some of the data on this. So absolutely, new government emphasis is around health inequalities, is on healthy life expectancy by region. So we're yet to see the detail of what that's going to be, but really positive. Exactly as Victoria says, we've had that stalling in improvements in life expectancy and healthy life expectancy since around about 2010. Overall, the gaps have widened over that time. It's a general trend between most and least deprived. We do have the headline level of life expectancy for Leeds, so we can compare Leeds to the England rate, for example, and actually what we saw certainly leading up to COVID was a worsening picture for Leeds compared to the England average. So you've got sort of two bits of inequality, if you like. You've got the inequality within Leeds, and you've got the inequality between Leeds and the national picture. So we can absolutely say that leading up to COVID, we were seeing a worsening picture in Leeds compared to the national one. That was obviously a real concern, and we've every reason to believe that the gap in Leeds would have been widening as well, reflecting the national picture. And we're just showing the data up to COVID because it's actually been quite skewed. A lot of the mortality and life expectancy data has been quite skewed from there, so there's still work to do to kind of work out the picture since. But that's the general trend. That's the backdrop, I think, to approaching the recommendations and the work in this, and the sort of Marmot broader health inequalities work in parallel to that, I would say. And yeah, we're hoping to get the data soon to be able to do that greater breakdown within Leeds.
Super, thank you. I'm going to bring in Councillor Ritchie next.
Thank you. Just to echo everyone's comments, positive comments about the report. This is the second one that I've kind of been involved with since being on this board, and very impressive piece of work. I'd just like to reflect as well and comment on welcoming the intersectionality that's throughout the report as well, not just on age, but the other protected characteristics are referenced. Just a couple of things from the report. In terms of the snapshot, Victoria alluded to a comparison with sort of the younger age group with that we can see where things are going. I just wonder if that would have been helpful, but I know your slides then get a bit messy, a comparison with say 20 to 50s just so that you can see the direction of travel, which you've mentioned that. But again, I understand why you can't have everything in the report, and if it's in there, you're going to tell me it's in there. Apologies if I've missed it. And the other issue that I'd marked up was on around, I think it's the health section, and particularly in relation to menopause. I'm aware of one issue at the moment is actually access to the drugs, the prescription drugs for that, which the pharmacists cite as Brexit being a factor. But just to push that wider, is that not something that people have brought up, that access to medication, particularly as new medication comes online and you're waiting for it, you know, I'm thinking dementia drugs and what have you, and having that technology, access to it while you're waiting for NICE to authorise them perhaps, and the cost to the NHS and that general access. But I am, as I say, aware of menopause drugs, the availability of those presenting challenges for many women currently.
So thanks for those comments. In relation to kind of the snapshot and how we split the data, we had lots of discussions around how we might do this year. So last year the snapshot took, I suppose, more consistent approach in comparing Leeds with areas of deprivation in Leeds. Because you mentioned, Councillor Ritchie, the intersectionality in which, you know, the way in which we looked at the data within this report, and for the purpose of the snapshot, we pulled out kind of the most pertinent stat in relation to you know, various equality characteristics for particular topics. In the full report, where data was available for the 18 to 49 age group, we did try to make those comparisons between kind of under 50s and over 50s. And similarly, where we thought kind of maybe there might be other differences for the 50 plus age group, we did try to break that down a little bit further. Do you want me to talk about menopause as well? So I think in relation to menopause, this was probably a surprise for us because we asked people very open questions in the report about what helps them to age well, what was a bit of a barrier. We did not kind of give menopause as a prompt, but quite a lot of people did talk about menopause. In terms of the things that they talked about, they talked mainly about access to health and care and kind of issues and getting that diagnosis and the support, but actually as Aisha talked in her in the film, that once they got that support they kind of could understand the symptoms, and a lot of people did talk about symptom management as being kind of one of the complexities in relation to aging well with the menopause. But yeah, that was one of the key areas. In the next couple of months, regionally, there's going to be some seminars, webinars, one for health and care professionals around ageing with the menopause, and one around working through the menopause, which I've shared with partners across the system as well. So hopefully that will give partners across the system a lot of insights around kind of good practice as well.
If I can just, the other part of your question, Councillor Ritchie, I think was about that sort of wider issue that's often very high in the news and quite prominent about particular groups being concerned about access to particular drugs, which, as you say, might not have been NICE approved and the like. Now, I'm going to sort of check with Helen, but my feeling is that didn't come up as an overarching theme at all, really, and I think that go as far as to say it probably reflects a lot of those things are very high profile in the news, but affect often small groups of people and aren't necessarily the biggest issues across the breadth of a population about what they feel are those most important things that affect them in that broader sense of aging. And that isn't in any way to downplay the significance and huge importance of those particular access to those particular drugs to those individuals concerned at times, but I think it was interesting that that didn't come through at all when we had those open conversations through both survey and sort of focus group type conversations. That wasn't at all, didn't come through. Thanks.
Good, thank you very much. I can't see anyone else indicating, so I'm going to bring this item to a close. I just want to say again, really comprehensive and interesting report, and I think you're really right to highlight the healthy life expectancy, and I think that's something that's sort of going to sit with me for a while, because it's uncomfortable reading, as as it's has been said several times. Like last year, you brought back sort of a sort of progress on last year's report, and obviously we'll want to see that again for this year's report, because it's hard to know how, because we want to see what action, like impact the action has, so that is important as well. So thank you very much. We've been going for just over 2 hours, so I'm going to just have a short break before the next item, if that's all right. If you look at the clock at the top, we'll come back at 20 to 4. If people can be back in their seats by then, that'd be helpful. Thank you very much. Had a brief adjournment, but we're now back online. Can I start by asking our new colleague who's joined the table to introduce themselves, and then we'll move on to the substantive item. Thank you.
Thanks, Chair. My name is Carmel Langstaff. I'm the Chief Officer for Transformation and Innovation in Adults and Health.
Thank you very much. Okay, so next agenda item is item 9. It's page 125 of your packs. A really important item about direct payments. And I don't know if Councillor Arif wants to say some introductory remarks. Thank you.
Yes, Chair. So if you recall, we as exec members were asked to sort of give our opinions on what we thought would be perhaps an appropriate discussion to come to scrutiny, and this was something that I suggested. Essentially, direct payments enable people to who draw on care and support to choose and arrange and manage the services they need themselves. We are unfortunately, in terms of our uptake on direct payments, it is low, even though we've got lots of great work happening. So really just wanting to draw upon the board's experience and thoughts or any comments they feel they can contribute towards this piece of work. As Carmel's in the room and Shona, the report's quite good. It goes through all the things that we are doing, but as I say, it is an agenda where we could be improving. So looking forward to the discussion. I'll pass on to Shona to take it from here, Chair. Thank you.
Thank you, Councillor Arif. And as you've just said, really welcome the opportunity to have this challenge session around how we can improve take-up of direct payments. Angela, there's a slideshow. Only 4 or 5 slides. People will be pleased to hear. So, when care and support, so they have eligible needs, we offer them a range of ways in which their needs can be met. Sometimes that need is met through a short-term service like reablement. Sometimes it's met through a range of services like telecare, or it might be home care or an ongoing care service such as a care home. And one of the ways in which that service can be picked up is through a direct payment. Direct payment means that you get an amount of money in your bank account, and you can then spend it on the care that you need, and it gives you the choice over that level of care, how it's met, how it's delivered. As Councillor Arif said, in terms of our performance, we're at 14.9, I think slightly higher now, but 14.9% of people who use care services received that through a direct payment in 23-24. Our approach in Leeds, providing choice in relation to managed budgets, we don't require people to take about a direct payment. We do offer them the opportunity to have a service delivered through a managed budget, which is where the local authority takes responsibility for arranging and paying for that care package. That's a little bit different from some other local authorities who are much keener that people arrange that care themselves. When people do take a direct payment, what they'll tend to do in Leeds is use this as an alternative to home care. So they'll employ a personal assistant, and employing somebody carries with it the responsibilities of recruitment, selection, and obviously paying and managing people. That leads to one of the wider challenges that we have had in the last 3 or 4 years, which has been availability of personal assistants. We haven't had a huge number of people to draw on. And then the other challenge we've had is our own direct payments process is complex and lengthy, and tends to mitigate against people wanting to have their immediate needs met if they have to wait for a few weeks, and also go through a lengthy process and also recruit people. If there's a readily available home care service that's flexible and suitable, they'll tend to choose that option rather than go through a direct payment. Having said that, other local authorities perform better than we do, and therefore we know that there is a stretch and that we can improve. Can we go to the next one, Angela? So we know that the Care Act allowed us 10 years ago to move away from care management, which was an approach to assess somebody's needs and then put a package of care in. It tended to be quite limiting. The Care Act introduced a strength-based approach, and we embraced that fully in Leeds by ensuring that our social workers understood what was available in the community. We have a huge amount of third sector support, but we also have in the community a lot of resources that people can rely on for daily support, knit and natter groups and that kind of thing. There is a lot available in Leeds. We're such a giving community that there is those things available. And we're not a vastly rural community where people are spread out. So we know that people have the opportunity to access services that meet their needs for companionship, for well-being, without needing a directly provided care service. We're also aware from some of the performance reports that have come to Scrutiny previously that there has been a huge amount of demand. At a time when we lost a lot of social workers and we had vacancies, we also had an increase in demand. And as a result, we've seen a lot of people coming to us later with more of a sense of crisis about their needs and therefore needing a more immediate solution. We've also got within Leeds a broad range of accessible, high-quality services for people with mental health needs. And you'll see in a minute that our take-up amongst people with a mental health need is lowest for a direct payment amongst the other groups. And I think that some of it is down to that range of available accessible services that people don't need a social worker necessarily to access. So it's easier for them to take part in community activities without that support. Where we do have a positive take-up of learning disabilities is, direct payments is people with a learning disability, where we have people receiving 24-hour care as part of a package through a direct payment. They or their family member will recruit a team of PAs who will then support them to live the life they want to lead 24/7. So we know that we've got some really successful case studies and stories where direct payments have worked so well for family members. Also for people with learning disabilities, it will be part of a broader care package. Somebody might use a day service, somebody might have respite in a residential respite unit. They will also have community support on a weekend to help them to go out and about, functions as respite for their family, but also gives them choice and control and something to do that they're interested in. So that's where it's been working, and we've got a really good track record for people with learning disabilities. And Angela? So in the last year, we've undertaken some improvement activity. We have engaged people themselves, their families and the carers to better understand their experience of direct payment. And that's how we know it takes too long and it's too clunky. We have promoted direct payments quite heavily through a whole range of opportunities. Website, our in-house services have been promoting direct payments quite heavily. We've been identifying opportunities to improve the direct payment process. We've looked at what other people do. And sometimes there's not much difference between what we do and what they do, but we do need to really look at best practice and learn from that. We've established an innovation group and recruited direct payments champions. So we know we've got support within our social work group for the direct payment process. It's not something that they don't want to do. It's something that they appreciate and value, but it takes too long. We've delivered training on direct payments to, it says 209 social workers in the report, 90 on the slide. So we have delivered training direct to social workers on that basis. We have made it easier for professionals to access information through the direct payments team. And also every social worker has been asked to think about direct payments, and as part of their conversation with people to justify why direct payment isn't the option that's suitable for that individual. So taking a default in rather than a, leave it out process. So everybody has a conversation about direct payments. The Leeds directory, which I would plug any time because it's a really, really good service. There is information in there and also on the website. And we started to look at people that we think would completely benefit from having a direct payment. And we're looking at increasing the number of personal assistants. As part of that, we have engaged a company called Current Care, which is a matching service, a website where you can go on and say, I need a personal assistant, but also personal assistants can go on and say, I need work, and it matches you. And we found that quite a successful option as well. That's at no cost to the local authority. Thanks, Angela. So in the last year, we've developed a direct payments dashboard, and that's where I've drawn some of the information that I've presented to you today. You can see the bar for mental health services, which is the second smallest bar, demonstrates that 6.9% of people have access to a direct payment from a mental health service. The other ones are our areas. So East North East performs best, with 16.8% of its people having a direct payment. And then the best performer, as I said earlier, is learning disability services with 18.9%. So almost 20% of people with a learning disability receiving a direct payment. If I go to the next slide, Angela, and come back to questions on the detail if required. So the plans that we have, we're developing our direct payment team. We're wanting them to work much more closely with our social workers so that when somebody goes out and has a conversation with a person and they want a direct payment, the direct payment team can then turn up straight away and start to talk to them about setting up a bank account and doing the work on becoming an employer. And the social worker can then move on to the next person rather than them getting bogged down with the detail. The process we do need to, and we are working on ways in which we can reduce the length of time it takes to set up a direct payment. Stories that social workers who have to get a signature from somebody to a piece of work, trying to visit the home 3 or 4 or 5, 6 times to get that signature. Obviously, that's a huge waste of everybody's time. So is there a different way of doing that? Yes, there will be. So we're looking at that sort of thing. We have been doing targeted engagement, so undertaking work across different groups of people who draw on care and support. We've been to the Forum for Race Equality, Social Care and Health and talked to them about direct payments. We've been to Leeds Evolving People, talked to them about direct payments, and we're having to get out and talk to an even wider group of people to really celebrate and sell the story that people can have control over their care and support. And then the last one is that we need to develop more personal assistance to continue to support when somebody wants support and we get them through the process quicker, there is somebody there who matches their needs and requirements, who can help them to live the life that they want to lead. So that's the end of the presentation, and any questions?
Thank you very much. It's very helpful and interesting. Just a bit of context at the start. I guess all your language has been higher number is better. And I guess I just wanted some context on whether that's always the case. Would 100% direct payments be the end point? Thank you.
I'll take that one start if that's okay. I know that there are some local authorities who really push their targets around direct payments take up to the extent where the choice element is somewhat removed, and people are directed as this is your first option, and only when people very clearly saying that they don't want to have a direct payment will managed service be offered. I also know that there are lots of local authorities that will say to people that they have the choice of going to any one of the providers that are on those councils' approved provider lists for home care, for supported employment, for mental health services, and will say, well, this is your personal budget allocation, we'll pass it to you as a direct payment, and these are the agencies that deliver care, the sorts of care and support you need. By all means, make your own arrangements. So high number of direct payments in local authorities doesn't necessarily equate to best offer for people, because often it can actually limit genuine choice.
Thanks for that. That's what I thought you might say. Thank you. Okay, I'm going to bring in Councillor Gibson, and anyone else who wants to ask, please indicate.
Thank you, Chair. I mean, everything that you've said is absolutely spot on in terms of your analysis and, you know, what's wrong. It was, you know, as a social worker, it's faffy to set up. You know, you're advising people that actually it's quite difficult to become, to find a PA, then you become an employer. That scares people off. But of course, when it comes to working with people with learning disabilities, the flexibility that it offers as well as being able to sort of design a package around having care whenever you want it, and then also having a little bit less over, because actually grandma can cover on a Friday evening, which means I've got a little bit for Saturday morning, so somebody can take me to the football. It works really, really well. So I think everything that you've said is absolutely spot on. In a different authority I worked with, we basically used to just sort of say, do you want a direct payment? And then we'd work with some payroll companies, and then we'd just ring them up, and they'd go sort everything out from their side, which worked quite well. But you're setting up a direct payment team anyway, which sort of do all that work and will be much better in-house, obviously. But yes, difficult, but certainly a lot of good opportunities if we can get more people onto them.
Thank you. I think I'll take that as a comment, if that's okay. Yeah.
I don't have any suggestions.
Hey, good. Okay, thank you. I'm going to bring in Jane.
Thank you. I guess mine probably is a bit more of a comment rather than anything else. I mean, thank you for a really clear, transparent paper in terms of the situation. I read it as it looks like some local authorities are kind of chasing the target and missing the point in terms of personalisation, and clearly that's not the value base that you're wanting to come from. So I completely recognise that, but there's also within the paper the recognition that actually direct payments can provide a lot more flexibility. So there is that balance, isn't there, between that nuance. I suppose I do have a kind of question in. Clearly, this is a CQC interested KPI, isn't it? A KPI of interest to the CQC. What is their level of, I don't know what the word is. If you tell your story and then you can show your drive in the personalisation flexibility element, will that help? I guess is what I'm asking, really.
I'll take that one as well, if that's okay. So the short answer is absolutely yes. If we can demonstrate that we are offering people genuine choice, and that we're making things as easy as possible for them, and that offers that might include a managed service still means the delivery of very personalised packages of support and care, then without a doubt CQC will understand that we're not compromising on personalisation and on choice. The most important thing that CQC look at in terms of our Care Act duties is whether we are offering people the maximum choice and control about the way in which their care and support services are arranged and delivered, and if they've got any concerns about them, that then those things are being addressed. So if we can demonstrate that somebody receiving the service through a managed budget, through a provider that we've approved, and they're not happy with that provider, and if we can show then that we've worked with the provider to ensure that that person's voice is heard and that the changes that they require are made, then we can demonstrate that even through a managed budget, it's a personalised offer. If on the other hand, it's a case of, well, that's the offer, take it or leave it, then absolutely not. Then what we're restricting people's feedback, the bit around control, that they have no say and control in how their service is delivered to them. So you're absolutely right. It's in telling the story around why we feel that we're not compromising people's choice and control when we're not really pushing direct payments. If in fact that we are respecting people's choice by not pushing direct payment as the main way of a service being offered to people. But that's not to say that we don't still want to promote direct payments, because just as you say, Jane, it can really allow people to have flexibility and agility. They don't have to have regular services fixed at particular times of day. They can say, you know, tomorrow, instead of coming at 10, please can you come at 11? You can't really do that with a home care agency because they've got rotas and they're relatively fixed. So the agility is less than if you've got a direct payment. So there are definite reasons why direct payments would be a good option for people in terms of that bit around flexibility and control.
No, follow up? Yep.
I mean, and that's what I anticipated you to say. So yes, so I mean, the only other kind of question I would say is you've covered off all kind of elements of, you know, what you need to improve. You, just in reference to learning from other areas, you say you were doing everything already. So is there no other peer area that has a similar kind of challenges that have turned the curve? Isn't there no other area you can learn it from?
I think there are. I think that some local authorities have. We've got a plan. Some other local authorities are well ahead with implementing a plan where they've wanted to turn it around to make direct payments much more accessible. One of the areas that we have struggled with is that we've worked with a provider around direct payment support service and managed accounts, a bit like Councillor Gibson you referred to, and our relationship with that organisation hasn't been wholly successful or to our advantage. It has been very much determined by the way in which that organisation wants to work, and we've recognised that, and therefore we transferred some of those staff from that organisation back into the council's employment. They used to be previously employed by the council. We've brought them back in. They're bedded into our teams now and are really changing the way that our social workers see direct payments. So we're beginning to do the things that we know some other local authorities have managed to do more successfully or at a quicker pace than we have.
Thank you very much. Okay. I'm going to bring in Councillor Ritchie next.
Thank you. A very short question, and then there might be a follow-up. If you go back, you can. So the follow-up will be, do you find that people do that? Again, this is based on experience, which I recognise is a really small, anything that comes to us is the minority, but people have had issues with billing, in my experience, particularly when they may access a provision, sort of a weekly provision, but then have a couple of weeks off, and there's issues with the billing, which may be causing issues. So are those sort of experiences, which I'm sure you're working to deal with, does that put people off? Do you find that they do return from direct payments, or people are hostile because I've heard from a friend it's not a good process kind of thing?
So the charging does work in a very different way. We have what we call a prepaid card and a separate sort of basis of monitoring how much of the direct payment fund is being utilised, and we claw back what is not utilised. What you describe actually is more relevant to people who receive a home care package from a managed service, because they might decide that they don't need a home care visit on a particular day, but because they haven't given enough notice, the home care agency hasn't been able to cancel the call or re-provision their rota there, so their staff still have to be paid, so they still have to pay for that late sort of cancellation or not wanting that, refusal of wanting that service. With a direct payment, there's more of an opportunity to not have that money clawed back, because you're in control. You can say, no, I don't want a visit tomorrow, I'd like it on Thursday instead, please. And as long as they're working with their PA
that they've employed or the agency that's delivering the service to them, then it allows them that sort of ability to say, don't charge me for this, but I'll use that slot on a different date. So that's my take on things, but I'll let Shona in if you wanted to add any more to that, Shona.
Thank you, Caroline. Councillor Ritchie was asking a question about when do people come off a direct payment, and quite often that's if somebody moves into a different level of care requirement. So if they move into a residential care, or if they move from the family home into supported living, and they're getting their care needs met not in the family home but by a care provider. And so that's often what we see is people's progression of needs from relatively lower level into needing more of a service. But what Caroline said there about the payment issue, I think, is absolutely right. The benefit of a direct payment is being able to have a direct relationship with the provider, either your PA or somebody else, and then you're in control. One of the things that isn't in the report, but we are looking at developing, is individual service funds, which is where we pay a provider an amount of money for that person, and then that person has a relationship with the provider, and they're in charge of what happens in that care provision. And that's another way of giving the person choice and control over their service without having to become an employer. So we're developing other ways which aren't direct payments but are different approaches.
Thank you very much. Okay, Councillor Runtree.
Thank you, Chair. I'm just wondering about potential targets for and whether you think a target for the percentage of direct payments would help to drive change. I mean, there is a reference in the report to working towards a target. I wasn't clear whether that is specifically about the client group for people with learning disabilities, or if that was like looking for a target for the whole. I just wanted to know your thoughts on whether you would envisage having a target for each client group or some client groups, or for change the whole, whether you think that would help. Thank you.
We certainly do. There's a target set that every social worker will have a conversation, which means that we're socialising the idea and we're helping to make sure that people are exposed to a direct payment as an option. But I think we ideally would want to shift the dial into the early 20s in terms of the percentages. When you look at where the local authorities that have got the highest level, they tend to be, what Caroline was outlining, is they're taking a choice which we don't feel has any more choice or control, in fact. So we're not wanting to go for that 50% of people in receipt of direct payment, but I think more like 22% would put us in a better position in terms of the group of local authorities that are at that lower end. But that would be a starting point. It wouldn't be an end point. So obviously, if we find that people are really keen that we get the systems right and we get the processes correct, then we'd have no upper limit on that in terms of what we were going to do in terms of direct payments.
Thanks. Is there any research or evidence that would tend to suggest what an optimum level is? And I appreciate, obviously, that very much there's a lot of dependency on the local authority and the demographic character of it, so it's very difficult to say. But is there anything you can look to that's helped to inform you? Is that where your low 20s figure has come from, perhaps?
From my perspective, yes, we haven't done masses of research in that area, but you can see that there are some local authorities in the 40s, and they tend to be the local authorities that rely on a direct payment as a form of first choice. And then there's another load of local authorities that are around about the 20s, where it feels like they're taking a more nuanced approach. But we will do that research. I think that's a really good prompt, and see whether my initial view on that is correct, and then we'll move forward from there. Thank you.
Okay, thank you.
Thank you very much for that, Councillor. Okay, I think Councillor Gibson wants to come in.
It's just to say, I don't think direct payments are a panacea. It's not. I don't think we should be pushing them on people. I think the approach that we're taking as an authority is the right approach. We offer them, and in my experience as a social worker, you know, there wasn't a great uptake. You know, people weren't coming to me with alacrity to be like, I really want a direct payment. Some people would have heard about them because they wanted flexible packages, and that was absolutely right. And I'm sure that there are some people in the city that have missed out because perhaps we could have done a little bit more, and a direct payment might suit them a little bit better. And that's probably the extra 5% that we're talking about. But what I don't want, or I would hate to see, is us as a local authority shift towards what some authorities have done and try and push direct payments on people, because they can be difficult to manage. They come with a lot of responsibilities, and if somebody's stressed out because they have physical health or mental health or whatever difficulties they have, having to deal with a direct budget or even a family member, direct payment, sorry, or even having to liaise with a payroll company can add extra stress, and I don't think it's something we should be pursuing. So I'm glad. I think the approach that we've taken is balanced and right and supportive of it.
Thank you very much for that, Councillor Gibson. I agree with what you're saying entirely there. Good. I can't see anyone else indicating to speak. So with that, I think Councillor Gibson summarised broadly what the board has been saying, so that's really helpful. Thanks for your time on this, and I do think it's something that we may want to come back, because it feels like there's still a journey on this, and understand the progress on that. But with that, I'll close this agenda item. Thank you very much for coming. Good. Okay, so we're going to move on to item, the last item, item 10 on page 133. Just a couple of things from me at the start. So just a quick update in terms of the vaping work. I think there's still obviously we did some work with children and families last year in terms of young people vaping, and I think there's still work with the sort of national picture in terms of bringing in legislation to change that. But I think there's also work that we need to do locally with partners such as like the Trading Standards Agency, which I continue to get reports about young people being able to buy vapes when they're underage, and I think that is something that we should support our sort of across the city, making sure that happens. The second thing I wanted to raise was the email Angela sent on my behalf actually yesterday around the complex rehabilitation programme, which the proposal from the NHS is to move the Leeds York partnership with NHS Foundation Trust to move it from Seacroft to Armley as part of the sort of service improvement programme. My proposal, as discussed earlier in the pre-meeting, is to have an additional members meeting to discuss that, probably on Teams as soon as possible, to talk about the proposals and the pros and the cons of that. And so I guess I'm seeking your agreement on that. Unless anyone disagrees, I can see agreement around the room, so I'll take that. Good. Okay, so those are my 2 points. Is there anything any members want to raise on the work programme? No. Great. So with that, I'd like to thank everyone for the time. I think it's been another helpful meeting. Lots discussed, and I look forward to seeing you next time. Have a good afternoon. Okay, bye.